Okay, hi everybody, welcome back. And you don't need to boot up Top Hat right now because I'm trying to finish the entire autonomic nervous system chapter by the end of this class because we have only two full more content lectures. Then there's a review session on Wednesday. Oh, and also next week, Monday, I actually have to pre-record that one because I'm running the simulation lab for this medical students all day Monday. So this is why, I think my last live full lecture will be this Friday, and then Monday will be pre-recorded, then review session on Wednesday. But if you go to Top Hat after this, what you can see is that we almost have all our assignments for Top Hat. And this one is a little different. So this is kind of a fun one. It's meant to be pretty easy, so don't overthink this one. But what you do is just click this Google form right here, and it'll take you to this Google form. And basically, it's a sympathetic or parasympathetic writing activity. Like if you were here at the end of our previous lecture, we did this little game where you kind of said like, hey, is this sympathetic or parasympathetic? Now it's your chance to come up with your own situations that are sympathetic or parasympathetic. So you just write this, and then you use, there's a writing prompt, you just do one sympathetic one, so you go like, don't put this by the way, but you just put in that. So sympathetic, and yeah, but don't put that, I'm just doing this for examples. And then you do parasympathetic, and then you're done. We'll check it and see like, okay, are you actually describing it? And one thing with parasympathetic, again, if you were here for the last lecture, you know that parasympathetic also involves things using the bathroom or the reproductive systems. Now, I want you getting very explicit, so my rule is like, yeah, you can't mention things like, it's always kind of tough, like not, especially like doing this online class and broadcasting, not to get too explicit. So for if you're trying to talk about things like diuresis, defecation, or anything reproductive, try not to be overly graphic. So my general guideline is like, if you're teaching someone about the parasympathetic nervous system, like a classmate or someone in polite company who's, I mean, they might giggle a bit, but you won't like totally like creep them out by just gross them out by how you're describing it. So yeah, something you would say in an educational concept. So again, nothing very explicit that would probably get you like you kicked out, like shut down a YouTube stream or something like that. So that's for the sympathetic and parasympathetic. So that one is pretty easy. So again, it's like to supplement and give you a little fun activity for the one of our homework assignments. Okay, so now let's finish off with the autonomic nervous system. Again, Top Hat, you don't need to open it right now. We have a lot to cover. Now, dual innervation. Let's see, ChemApp 220. No, it's not. So Chem 220, like, no, this isn't something that's due today. It's due by the end of the semester. So yeah, you can do it whenever. Okay, so dual innervation. So this is an important concept when you're talking about the autonomic nervous system because often you have sympathetic nerve fibers and parasympathetic nerve fibers running to the same tissue or organ. So this is what dual innervation is, like dual shock or dual anything. Dual means two. So this is when an organ has both sympathetic and parasympathetic nerve supplies. Now, usually, not always, but typically when you have both sympathetic and parasympathetic fibers innervating the same tissue, one does the opposite of the other. So this is most of the times you have this, but there are a few exceptions. And this is another important thing. Even though many of your tissues in your body that are under autonomic control have dual innervation, not all of them are dually innervated. Now, such as your erector pili, right? So the ones that gives you chicken skin, the goosebumps, the little muscles we have attached to the roots of our hairs, and causes our hairs to stand on end when we're like encounter cold or certain situations. So these do not have parasympathetic fibers; they only have sympathetic activities. So again, this is not dually innervated with the erector pili. Now, systemic blood vessels, this is where it gets a little tricky. So sympathetic, the thing is that it depends where it is. The sympathetic nervous system, remember that sympathetic is fight, flight, fright, or freeze, and then parasympathetic is rest and digest. So sympathetic is not going to really help with the rest and digest response. So what the sympathetic nervous system is going to do is put the brakes on the rest and digest. So it's going to constrict and constrict, like if you have like a hollow tube like this, it's going to squeeze, so it's going to narrow it down. So it's going to kind of deprive blood flow to and from your gastrointestinal tract or your digestive tract. So you're going to slow down the blood flow because it's not really the time to rest or digest. But the thing is that if you're doing fight or flight, what do you want to do? You want to supply your skeletal muscles, especially if you're planning to fight, run, or run away. So what you want to do is, instead of it constricting, you want to open up those blood vessels. So it depends where it is. Like systemic blood vessels for sympathetic activity, you want to shut off blood supply to the organs and tissues that don't need blood during a sympathetic activity. But you want to increase blood supply to things that are doing the work, like your brain, or actually your brain doesn't really change that much. It's kind of tricky, don't worry about that. But definitely your skeletal muscles, you want to increase the blood supply to that. Now parasympathetic is conflicting information, that's what I'll get at here, and this is another disclaimer I have. This is another reason why the sympathetic, especially the nervous system, I predict is like if you keep on updating this OpenStax or the OSU book or whatever textbook, it's going to change. It's going to change 5-10 years, and so when there's conflicting information or a debate, I don't test you on that because it could change the next year, and then it's like, okay, that was wrong. So just know that it's kind of under debate whether parasympathetic activity affects blood flow to the GI tract. I mean, it makes sense if it did increase it because then you're digesting, so you want to absorb all of those nutrients, but there is conflicting information. So Martini says there's no parasympathetic innervation of GI blood vessels, but other sources like this physiology review say there is. So this is why, if you're using the Martini book, and I think the Martini book, to be frank, I think it doesn't really update that often. They just want to put out a new edition every year so that they can increase like book prices, but that's editorializing. This is why we're using OpenStax. Okay, so then parasympathetic nervous system, it's interesting. So it doesn't really affect the skeletal muscle blood vessels. So yeah, when sympathetic activity increases blood flow to skeletal muscle, but parasympathetic, no real effect. So again, it's not directly opposing it where it's constricting the blood vessels, but the main guess here is like, okay, parasympathetic, you want blood flow, or sympathetic, you don't want blood flow to your GI tract, and sympathetic, you want blood flow to your skeletal muscles. Parasympathetic is kind of muddled. Now, sweat glands, they have sympathetic activity, and that makes sense, right? When we went over those laundry lists of all the sympathetic responses that we have when we have sympathetic activation, sweat glands were one of them because, again, you're increasing your metabolism, you're increasing your activity, you're increasing your heat production, so you want to sweat so you cool yourself off for temperature homeostasis. Now, with sweat glands, it's going to, what do you think? Increase your sweating. So the sympathetic activity is going to stimulate these sweat glands and cause them, especially the water-based sweat glands, to secrete more sweat so it helps to absorb and dissipate heat from your body. Now, parasympathetic nervous system, we haven't found fibers, or if they could have found fibers, maybe I have to check again. I always have to check because they're saying, oh, we found these new nerves in this one place. So this is, but as of the writing of this, maybe a year ago, they didn't find fibers. So sweat glands are not dually innervated, at least I have to check it. I check it every single year. But the thing is that parasympathetic nerve control of sweat glands isn't really known. Now pupils, so again, those little holes that, and when we talk about vision, we'll talk about vision on Friday, but the pupils are the holes in your irises that allow you to light to enter in your eye, right? So we'll get more into that on Friday, but what happens, or if you look at your eyes, that black dot, that's your pupil. So dilation, that's a very useful term, especially next semester. So dilation is like, again, if you have something that's a circular object, dilation is going to increase the size, or actually dilation just means increasing in size, period. Constriction is when you shrink. So dilation, what's going to happen when you have sympathetic activity? It's going to open up your pupils, and when you open up your pupils, you're allowing more light in. So this is what you'll see. Your pupils will dilate and increase in diameter. So you can think dilate, diameter, increase in diameter. Now what happens is that when you get that, you get increased light coming into your eye, but your range of field, your vision field starts to narrow, and you start to get tunnel vision. And this is another cool thing, like say you're afraid of the dark, or a lot of people, this is common fear and phobia, being afraid of the dark. And what happens is, what are you most likely to activate? Sympathetic or parasympathetic activity if you have a phobia of the dark? Well, that's probably going to make you, or pretend like all back in caveman days where you have like someone entering a cave and you don't know whether there's some bear or animal there ready to attack you. So you want to kind of be like, oh, I'm going to be kind of like up and amped and ready in case there is a threat. So also in the dark place that you're scared of, you want more light coming in because there's not much light there to begin with. So it kind of makes sense that your pupils would dilate with sympathetic activity. Again, you're getting more light, but you're getting a decreased field of vision. And this is why, again, if you suffer from anxieties or general anxiety disorders, this is why it's good to have tools and go to places like the CDSC with our campus so that you can get a hold of it. Because what happens if you go super sympathetic and you get tunnel vision during tests? And then you'll be like, oh, are you seeing the entire question? Are you reading the entire question? Maybe your focus is very limited because your pupils are super dilated. Now, hopefully you won't be this bad, but does it make sense to, if you want the full range of vision, to be sympathetic or parasympathetic? Well, if what happens with parasympathetic, your pupils are dually innervated, so what happens with parasympathetic activity is that you're going to have constriction. So this allows less light in, but as we will talk about with the vision and special senses of vision, you start to focus the light better if you start to constrict. And what happens is that with parasympathetic, instead of having tunnel vision, now you broaden your range of vision, so now you adapt for close vision and reading. So this would be helpful during a test or something you just need to read. So you restore that peripheral vision, and now you can see more. And don't worry about this question. This is more of like a med school, possible PT school question, so you're not going to be asked about that. But again, which would you rather have? This vision or this vision? Right. Okay. Alright, lacrimal glands. We'll also cover this when we talk about vision in the eye next lecture, but lacrimal glands are, so these are your tear glands. And what happens with sympathetic activity? Well, there's conflicting information, therefore I won't test you on that. So don't worry about that. And Martini, the old textbook, says there's no sympathetic fibers going to, or no activity with the lacrimal glands. But there's another study that says that they found fibers, but when you stimulate them with electricity, they don't really affect tear production. And there's another one that says that it directly innervates the gland and does affect tear production. So there's a debate, and I won't test you on that in terms of sympathetic, because again, there's conflicting information. I'm pretty sure there are sympathetic fibers based on, the majority says that there are sympathetic fibers, but whether they actually do something to the lacrimal gland and tear production, that's debatable. But what you should know is that you don't worry about the sympathetic for lacrimal glands, but for parasympathetic, you need to know. So parasympathetic, tear production, that is classic with parasympathetic activity in the lacrimal glands. So this is going to stimulate tear production to lubricate the eye. And then the thing is that if you have these drugs called anticholinergics that block the sympathetic nervous system, this can cause dry eyes. Because why? They're blocking the parasympathetic nervous system, therefore they're blocking tear production. So this is canon. This is what you should know for lacrimal glands and the autonomic nervous system. Parasympathetic, tear production. But sympathetic, that's the part up for debate. Alright, so quick poll, or just like ask the chat. Do you have a fear of public speaking? I know everything's like kind of, I mean, it could be a Zoom presentation, but say like you're back in person, hopefully, I mean, I won't even mention that issue that I don't want to name. I've tried to I'm so sick of all these variants, I'm not surprised. But say everything's best case scenario, things are back in person next semester, and you have to do a presentation in front of the class. Do you have a fear of that? Would you be kind of like nervous about it, or are you like, totally easy, cake? And let's end the poll. So it says 73% of you have a phobia of public speaking. And that's kind of cool, that percentage, because I actually, I had the link up elsewhere, but according to the National Institutes of Mental Health, like public speaking, about 73 to 75% of people have a fear or phobia of public speaking. It's called glossophobia. So it's a very common fear, and this is a percentage of Americans who fear public speaking. Now, they have American Fear survey, but now it's all about politics. But yeah, public speaking is a common phobia, and heights, bugs, snakes, I think. So this is a cool thing. Like a lot of this, it's a very common fear. Now, if you have a fear of public speaking, what typically happens to your mouth? And I mean, you feel your heart race. You feel you start to breathe a little harder, and you're saying, "Oh, this is definitely sympathetic activity." So how this goes hand in hand with the salivary glands that produce your saliva. So what happens to your mouth if you have a fear of public speaking? Well, if you have a fear of public speaking, you probably have that dry, sticky mouth. You're like, it feels like I have cotton in my mouth, because it's like, well, the thing about sympathetic activity is that it puts the brakes. It turns off the faucet that produces saliva. So if you have less moisture, it's going to get stickier and sometimes a little frothier. I've heard that as well. And this term is the medical term is xerostomia, and zero is a useful, or not zero with an X, so that's actually a really useful prefix meaning dry. Stomia referring to the opening or your mouth, right? So this is why you get that kind of sticky, dry feeling in your mouth if you have a fear of public speaking. Totally natural. Blame the sympathetic division. Now, parasympathetic, luckily your salivary glands are dually innervated, so if you're parasympathetic, and remember, parasympathetic, rest and digest, right? So when you want to digest something, do you want to increase your saliva or decrease your saliva? Yeah, if you ever tried to, or do one of those challenges where you try to eat like a cracker or something dry, it's really hard to swallow something dry, right? So it makes sense if you have parasympathetic activity that you increase your saliva production. So this is what happens where say you're like, or I noticed like, especially like if I've had a really rough day, I'm super tired. I notice that like sometimes I find myself drooling, or especially on planes, like I'm totally zonked out, and then I don't drool typically when I sleep, but I have a really rough day, that happens. And also what happens is, like, instead of having that dry sticky mucus you have or dry sticky saliva you have with your sympathetic activity, with parasympathetic activity, the mucus starts to thin out, so you don't have as much of that sticky solution and mucus in your saliva. So this makes your saliva more thinner and watery. Now, a little review of parasympathetic anatomy. So we talked about pretty much the head and all the parasympathetic fibers and activity that leads to that. And remember, a ganglion is a group of cell bodies, and what we have here is like all these ganglia. I italicized this because, again, I think this is more something for advanced A&P, but there are specific ganglia that supply these tissues and organs of the head and neck. Now, you have all these cranial nerves, and like 3, 7, and 9. But what's this big nerve over here? So 3, 7, 9 up there. And then over here we have this huge nerve that supplies all of this. And this nerve is called the... What nerve is this? Well, do we have time? Yeah, let's ask the chat. So what cranial nerve is this? Cranial nerve saying, yeah, if you don't get it right now, here's a big hint. Yeah, so like I try like just like how you have that long nerve supplying all these organs, you have this long area supplying all these areas right here. So I like to think of it, this is like vagus, cranial nerve X, right? So this is why the vagus is very important. You notice that supplying all of these internal organs right here in your abdominal pelvic cavity, or yeah, in their thoracic and abdominal pelvic cavities. So that's what we have here with the heart, lungs, and all of these digestive organs here and accessory digestive organs. So what's the difference with the parasympathetic fibers we saw with the head and neck versus the one in our thorax and our abdominal pelvic areas. Should we know which nerve supply what organs? Yes, you should, as much as I'm covering here. And this is one thing, one kind of weakness about the OSU one is that it's a little less detailed. So this is what you should know for this one. And yeah, cranial nerve 9 is the glossopharyngeal. So the difference between the head and neck ones is that notice that the ganglia, again, that swelling that has all those cell bodies, they're not within the organs and tissues themselves. But with here we have the thoracic organs, and here we have the abdominal pelvic organs. And notice that the ganglia are right here, right next or contained within the walls of these organs. So the head and neck ganglia, they have their own separate ganglia that are outside the organs. But over here with the thoracic and abdominal pelvic organs and these internal organs, we have these intramural ganglia. So again, mural, like the mural on a wall, so you think of it inside the walls, you have the ganglia. So again, this is something you see with the parasympathetic anatomy. You don't see this with sympathetic anatomy. Now, with the sympathetic activity in the heart, so let's go over the thoracic organs. With the heart, well, what happens to your heart when you're excited or you have something that's causing a lot of sympathetic activity? What does your heart do? Does it beat slower? Does it beat harder? Does it beat faster? Well, it's going to beat faster and it's going to contract stronger. So what happens is that you increase your heart rate, so that's how many times your heart beats per minute, and you also have increased force of contraction. So you're not only beating faster, but your heart is squeezing harder. So what does that do? Well, the main function of the heart is to circulate and pump blood. So if you're pumping faster and you're also squeezing the heart harder, then you're also going to increase the blood flow. So this is what happens with sympathetic activity. Well, hopefully you're not having a heart attack like this guy, but showing you this is why you get that pounding in the chest. Because again, you're going to try to increase something you call your cardiac output. We cover that more in detail for PHYL 142, so that's like a teaser. So sympathetic activity, increased rate, increased force of contractions. Now parasympathetic, the heart is dually innervated. So when you activate the parasympathetic activity, instead of beating faster, so think of it this way, sympathetic for the heart, that's the gas, parasympathetic is the brakes. So the parasympathetic activity is going to put the brakes on the heart. So you're going to decrease the heart rate and you're going to decrease the contraction. So your heart slows down, so it does, compared to the sympathetic activity, like, yeah, you're doing a jog around the block. Do you want your heart to continually beat fast as you're trying to relax and go to bed later on? No, right? So you want your parasympathetic to take over, so give your heart a break, because you're not needing that increased activity as much. So yeah, parasympathetic is going to slow, and we cover this more in detail next semester. Now the lungs, sympathetic activity. Now during exercise, again, my classic example for sympathetic activation, do you want your more air being delivered to your lungs, or do you want less air being delivered to and from your lungs? Well, again, your muscles are working overtime. You want to fuel them with a lot of oxygen so they're more efficient at generating ATP and energy. So you want more oxygen delivery. So what you're going to do is make it easier for oxygen to get inside your lungs. So what happens is that your airways, and there are many airways, you notice that it starts off big and then branches out into smaller and smaller airways. So these airways inside your lung, they're lined with smooth muscle, and remember, when muscle contracts, it shortens, right? So if you have a ring of smooth muscle, what's going to happen if you relax it? Instead of constricting, it's going to dilate and open up. Now, is it easier to squeeze through a wide open door or a partially closed door? Well, if the wider you open these airways, the more you can have airflow, or just like opening a window, a partially shut window versus opening it all the way. You're going to get more airflow through a very wider opening in a window. So same with the airways. If they relax, you're going to allow more air in. So this is what the sympathetic activity does. Now parasympathetic, what is it going to do? Well, the lungs are dually innervated, and it's going to cause it to close and constrict. Now you might be like, oh, it's kind of weird. Like, why don't we have it like where it's like, okay, we're relaxed, but this is where it's kind of often confusing. Like they think, oh, parasympathetic is going to relax everything. Not in this case. So the parasympathetic in this case is going to undo the widening you would have with sympathetic activity. So this is what is kind of blocked here, but it's going to constrict and narrow the airways. So parasympathetic activity in the lungs is going to cause the smooth muscle to constrict, thereby reducing airflow into the lungs. Alright, so now moving from the thorax to the abdominal area. So the GI tract, and we'll cover this more in detail next semester. So how about sympathetic activity? Well, remember that the parasympathetic is rest and digest. The GI tract, the sympathetic activity is not time to rest and digest. So you're going to decrease that blood flow with sympathetic activity. You're going to decrease blood flow to the digestive tract, and you're also going to slow down the activity as well. So not just blood flow, but just how much the stomach is churning, and also how much of these enzymes and chemicals they're producing as well. And not only do you have the stomach, you also have the pancreas that produces a lot of enzymes, and you have these secretions that help with digestion. But again, this is not rest and digest time, so you're going to slow all of that down. And the sphincters, so you actually have many openings. Like you have an opening here, a sphincter muscle there, here, and two over here, and actually have sphincters all around. So they're like little doors in the digestive tract along different areas that connect the different organs of the digestive tract and the exit as well. So all of these are going to constrict. So it's like if you're hitting a bunch of red stoplights along a straight thoroughfare. Like if you're going on a street and there's all the lights turn red, that's going to stop traffic. Same with the GI tract. If all these sphincters are constricting, they're going to stop the movement of flow and digestion. So because why? It's sympathetic time. Now parasympathetic activity, what is that going to do? Well, luckily this is pretty simple with the GI tract. Now it's rest and digest time. So you want to increase your blood flow. Again, why? Because you want that blood flow to carry nutrients that are being absorbed by the digestive tract to the rest of the body. And then you're also going to increase stomach activity and also increase pancreatic and stomach activity as well. And it looks like this image is overlapping, but the sphincters of the digestive tract, they're going to dilate and open up. Because why? Parasympathetic time, rest and digest time, open for business, open up all the doors. Now the liver, so I'm going to does many things, and the liver is like the unsung hero of a lot of the processes in your body. But for this class, I'm going to keep it pretty simple. So one of the main functions or main effects of the sympathetic nervous system on the liver is that it breaks down glycogen into glucose. And you might be like, glycogen, if you don't remember what it is, you might be like, that sounds familiar, but what was it again? So remember that you have your biological macromolecules, and glycogen is one of the ways your body stores carbohydrates. Now, remember that glucose is a pretty simple molecule, 6 carbons, but you can link glucose together and daisy chain it, and not just make linear chains, but you can also make branched chains of glucose, and a very highly branched form of this glucose is called glycogen. So glycogen is basically just a bunch of glucose molecules linked together in a branched network, like a tree. So this entire molecule right here is glycogen, which is made out of glucose. Now, what happens with sympathetic activity in the liver is that it's going to break down glycogen into glucose. And what happens is that this big molecule is going to be digested by the liver. Is going to break up the small molecule into smaller glucose molecules, and this glucose can now enter your bloodstream and be redistributed among your cells in your body. So the liver is an important storage site for carbohydrates, but if your body needs it, it can break it down to glucose. And that makes sense, right? Fight or flight, you're going to use up more energy, so you want to release, instead of storing energy, you want to release it and do a stimulus package to your entire cells and just sprinkle all this glucose so that they can have energy. So this is why it makes sense you want to break down glycogen with sympathetic activity. Now parasympathetic, this is rest and digest time, and if you're digesting something, you're probably getting increased glucose into your and carbohydrates into your system. Now, if you don't need to use all that carbohydrates, what can you do? You can store it up for later. So what it's going to do is increase glycogen synthesis and storage. Again, now it's no longer sympathetic activity. Now you have all these nutrients coming in. Maybe it's time to store the ones we don't need right now, so we can use it later when we actually have sympathetic activity. So with glucose and glycogen, so what's going to happen with sympathetic activity or parasympathetic activity is that glycogen is going to be made. So you're going to take all the excess glucose and make it into glycogen. Now, this is unofficial, but I like using this because, like, not only do I think, like, okay, associate sympathetic with exercise, but for the digestive system and a lot of these, sometimes let's ask the chat real quick. Just a guess, which do you think is the anabolic system? And if you need a hint, remember that anabolic is the opposite of catabolic, right? And catabolic is when you break something down. And therefore anabolic, just like anabolic steroids, is when you build something up. So which do you think is the system that builds something up? Pretty mixed, actually. So about 68 said parasympathetic and the rest said sympathetic. So the sympathetic nervous system is catabolic because why? You're actually breaking down your stores because, again, you're doing an activity that requires a lot of energy. So it makes sense that you would break down your energy reserves so that you mobilize it, and then your cells can break down those nutrients into energy. So this is why the sympathetic is sometimes nicknamed the catabolic system. So, and it's also involved with stress. And this is why if you have constant stress, like most of us these days, this is why things tend to break down, because you have this catabolic activity that's breaking down the molecules to free up energy reserves. So again, this is using up energy stores instead of actually building it up. And anabolic, so parasympathetic nervous system, like especially if you're into like fitness and you're into bodybuilding, you want to be anabolic, right? You want to build things up. And this is also why it's not just diet, but also rest as well. So why? Because you're starting to increase your nutrient absorption. If you have more nutrients, you have more building blocks to build things like proteins or build energy reserves like glycogen. So this is kind of like what happens is that it restores the nutrient content of your blood, because why? You're digesting things and you're also reintroducing these nutrients to your blood as well. And all the excess, well, you can store it for later. So this is why. These are nicknames for it. Again, widely not accepted by all textbooks and authorities on this, but I find it personally useful to think of it that parasympathetic system is anabolic, sympathetic nervous system is catabolic. Now we have our very important vagus nerve here, but we also have these remaining organs over here. So we have our urinary and reproductive system. And these are supplied by these sacral roots over here. And if you're going into like nursing or like, I think physical therapy probably important too. But yeah, if you're going on to professional health or in graduate school, you should know these roots like S2 to S4 innervates the urinary system and reproductive system. Now with kidneys and bladder, so again, diuresis is part of parasympathetic. So for sympathetic activity, it's not time to use the bathroom. So what's going to happen is that your bladder wall is going to relax. Now it might be like, wait, sympathetic and relaxation. Wait, does that make sense? But your bladder is right here, right? So if you don't want to urinate, do you want your bladder squeezing or do you want it relaxing? So you want to ease up on the pressure, right? Because the more pressure you have on the bladder, the more you have to go. So it makes sense that sympathetic activity is going to relax your bladder wall, and it's also going to pinch off that opening, or actually you have two openings, but it's going to pinch off the urethral sphincters. Why? Because you don't want that pee to leak out. You don't want urination at this point, so you're going to shut the doors and also relax the bladder. Now with parasympathetic activity, now it's go time, right? So now you're going to get diuresis. So the bladder wall is going to constrict, so it's going to get a little extra push, because why? When it constricts, it's going to increase the pressure of the fluid inside your bladder. That's going to make it easier to push out that fluid into your environment. Now the urethral sphincter is also going to relax because now it's time to go, right? So you want to open up the passageways, let the floodgates open, and let things flow, right? So parasympathetic, and yeah, so these people are super parasympathetic because yeah, they let things go. I know it's really hard to find things that aren't super explicit with urination, but yeah. So they're super parasympathetic in those examples. Now, this is where it gets a little complicated. Actually, like toward the end of next semester, we talk about the female reproductive system, and there's a reason why there are more lectures on that because it's fascinating. It's super complex, but it's actually pretty amazing. So it's also complex with autonomic nervous system and reproductive organs. Now, one thing is that it's not with sympathetic activity and the female reproductive organs, you don't want blood flow because it's not rest and digest time, right? It's not feed and breathe time. So therefore, the blood vessels are going to constrict when you have sympathetic activity. And this is where it gets complicated. So whether you have contractions, increased contractions, or decreased contractions, it depends on which sympathetic receptor is is present in the uterus, or whether there's actually a baby in there or not. So whether someone's pregnant or not, then that depends. So you can either have increased contractions or decreased contractions, and it kind of makes sense. Okay, you want it to push out when you're ready to come to term, but you don't want to cause contractions prematurely and cause delivery or loss of the pregnancy before it happens. So this is why it's very complicated. Don't worry too much about the contractions part, but just FYI, that sympathetic activity in the uterus is pretty complicated. Now, parasympathetic, the blood vessels part is pretty easy. So now you're going to have increased blood flow to this because why? Maybe you're going to use these organs. So it makes sense to have more blood supply to that. So you have increased blood flow to the uterus, the cervix, the clitoris, so all these organs, because now it's like, okay, if you're choosing to use it, yeah, maybe it's time to deliver blood to this area because you're going to use that. And you also increase glandular secretions as well because, again, this is parasympathetic time. Now, the male's reproductive organs. Now, the male one is pretty easy. So, sympathetic nervous system, blood vessels are going to constrict. So the interesting thing is that, they're definitely different in their internal and external anatomy. But in terms of their autonomic control and blood supply, luckily, both sets of reproductive organs work very similarly. So sympathetic, not feed and breathe time, you're going to constrict the blood vessels. But if you're a male and you're trying to maintain an erection, what's going to happen? Well, what happens during erection is that you have increased blood flow to the penis. So if you constrict the blood flow, then you're not going to get blood flow. So that's going to prevent an erection. So the interesting thing is that the sympathetic is going to decrease blood flow and therefore cause flaccidity. But parasympathetic, what you have is the opposite. You have, instead of blood flow being decreased, you have increased blood flow. And therefore, this is why parasympathetic activity is going to cause an erection if you have enough blood flow to the penis. Now, this is where it gets a little tricky, is that for sympathetic activity, it also does something else. It also causes ejaculation. So this is where it's kind of interesting. It's not quite so think of it this way. Would you rather, if you're a male and would you rather be parasympathetic first or sympathetic first? So this is where it's not just about which is predominant, but also about timing. And 1, mission accomplished. 2 is kind of awkward. So you want it to go in the right order because otherwise you might do something unintentionally before you actually want to do what you want to do. So yeah, little thought experiment and think about it this way. Which if you're a male, what would you rather have? Parasympathetic first, then sympathetic, or sympathetic, then parasympathetic? And again, this is also why maybe some people get it mixed up because you sometimes have both occurring in the background and sometimes one overshoots the other, right? Yeah, so yeah, and doesn't it involve some SNS-like symptoms? And that's why sometimes I've heard of situations where, like from urologists, where they're so excited that it affects their reproductive organs. So they're so sympathetic, it's starting to affect their activity in their bedroom. So that's why you also get these things. Like sometimes it is in their head because they're like, okay, their the wrong system, division of the autonomic nervous system is kicking in or being dominant at that wrong time. Okay, so we're going to go very briefly over autonomic nervous system pharmacology. And this is very important, especially if you're going to medicine, pharmacology, or nursing, because this is a powerful way of affecting, or many medicines that we use in, like, especially emergency situations, they affect the sympathetic and parasympathetic nervous system. Now, we have to go very briefly over these two terms, ligands and receptors. So ligand is a molecule that binds to a receptor, but in this case, I'm talking about protein receptors, these membrane receptors. So this is some sort of protein found in the plasma membrane of a cell that receives and a ligand binds to. So I like to think of it like a lock and a key, because why you have the lock, that's like the receptor, and the key is like the ligand that turns the lock and activates the lock. So membrane receptors, again, in this case I'm talking about the protein, the molecule, not the entire cell. So it's not sensory cells or neurons I'm talking about. You can have membrane receptors on sensory receptors, but they're not the same thing. So they both, when you have ligands, they bind to receptors and cause some sort of change in intracellular activity. And you can have different receptors for the same ligand. So different receptors can cause different changes. So in general, when you have ligand and receptor, this is kind of like the flow of activity. Yeah, and this is from Khan Academy. So ligand binds to receptor, and the steps in between depends on the cell, depends on the receptor, but you get some sort of change in the cell when the ligand binds to a receptor. So just like turning the key in your car's ignition turns on your car, a ligand binding to a receptor on a cell causes some sort of cell response. Now, agonists and antagonists, especially if you're going to medicine and pharmacology, you gotta know what this is. So agonists, just like in our muscles and movements, right? So agonist is something that does something, and an antagonist blocks or undoes something. So we're talking about ligands and receptors. An agonist activates a receptor, an antagonist would block off this whole thing. So it would still be a ligand, but it's going to block the receptor. It's also going to shut off this response over here. Now with the sympathetic nervous system, remember, like, if you need a review of this, go back to the previous lecture about preganglionic and postganglionic neurons. So we do have neurotransmitters between the preganglionic and the postganglionic neurons. And these neurotransmitters are ligands. So these are molecules such as the very familiar acetylcholine. And the receptor it binds to at this synapse between the preganglionic and postganglionic neuron are called nicotinic receptors. So it sounds like nicotine, right? And this is how we discovered it. We're like, oh yeah, nicotine activates the receptors. But it's not just nicotine. You also have your natural activator of this is acetylcholine. Now, what happens is this is, again, ligand binds to receptor. It's going to cause some cellular change. So the cellular change you have with the postganglionic neuron is it's going to release a neurotransmitter. Depends on where the location, depends on where it is. There are many neurotransmitters, but the main two are norepinephrine and epinephrine from the postganglionic neurons. So what we have here are these receptors, and there's not just one receptor that are found on target organs of sympathetic fibers. There are two broad categories and subtypes of these categories. The two main types of receptors are alpha adrenergic receptors and beta adrenergic receptors. And don't think so a common misconception is that, okay, epinephrine only binds to one, norepinephrine only binds to this 2 beta. Actually, either can bind to either receptor. So it's like epinephrine can bind to both alpha and beta. Norepinephrine can also bind to both alpha and beta. So a mnemonic for this is SAN-VEEN, and you're like, wait, what? What does that mean? Well, I'll break down the mnemonic. So sympathetic, that's why it's SAN. But the acetylcholine, this is where the SAN part comes from. It talks about this synapse right here. So what you have, the neurotransmitter at the synapse is acetylcholine. The receptors at this preganglionic, postganglionic synapse are nicotinic receptors. Now this part right here refers to everything from the postganglionic neuron and the target cell or organ. And again, don't get confused that think it's just epinephrine beta, norepinephrine alpha. It's not one-to-one. So either of them can bind to either of these adrenergic receptors. Now, you're like, wait, what? So let's talk about epinephrine and norepinephrine real quick. So epinephrine comes from Greek, so it actually means like epi, like above or outer, right? And nephron refers to the kidney, so it's saying above the kidney. That's where you would find the adrenal medulla, right? And adrenaline comes from Latin, so renal refers to the kidney, and ad refers to this location next to the kidney. So the funny thing is that both of them mean on top or above the kidney. So this is the source of these adrenal epinephrine, norepinephrine. So or one of the major sources of epinephrine, norepinephrine. Now, norepinephrine is the same thing as noradrenaline. So epinephrine is the same thing as adrenaline. And I think adrenaline is used more in Commonwealth countries such as Australia and the United Kingdom. But when you hear adrenaline, it's the same thing as epinephrine. So again, thus norepinephrine is the same thing as noradrenaline. Common misconception, norepinephrine is not the same thing as epinephrine. Adrenaline is not the same as noradrenaline. So it's just like this is equal to this is equal to this. So again, norepinephrine is not the same thing as epinephrine. It is related, but it's different. So epinephrine has this extra methyl group over here. Norepinephrine doesn't have that group. So they are different chemically. But whether you use epinephrine or adrenaline, it depends on the hospital, depends on the location. But again, adrenaline is the same thing as epinephrine. That's the main point here. So there is a difference between norepi and epi, and between noradrenaline and adrenaline, but adrenaline equals epinephrine. Yeah, so this is also an interesting thing too. Like it's also related to dopamine as well. This is how you're actually able to make norepinephrine and epinephrine and why they're so similar. They come from the same original molecule. Okay, so there's receptors in the autonomic nervous system. So this is an interesting thing. There you have the alpha adrenergic receptors, but there are two subtypes, and alpha 1 and alpha 2. And then the beta adrenergic receptors, there are three subtypes, so beta 1, beta 2, and beta 3. Now, both of them, so all of these receptors can bind to epinephrine or norepinephrine. This isn't a full biochemistry class, but there is different, like what they call affinities, for those of you who know a little more about chemistry. But yeah, don't worry too much about it for this class. And if you're using the OpenStax version, they have an error. And this is actually an errata I submitted earlier this year because I'm like, that's wrong. And they acknowledged it's wrong. So the OpenStax does have an error. It says there are three subtypes of alpha. That's wrong. Pointing out right here, there are supposed to be three subtypes of beta, two subtypes of alpha. So they haven't corrected it yet, but just FYI if you're using OpenStax. Okay, so to drive home the point, you have alpha 1, alpha 2, beta 1, beta 2, beta 3. And epinephrine can bind any of these. And same with norepinephrine. It can bind any of these adrenergic receptors. Now, you might look at that previous table in the notes and see like, wait, it says alpha 1 excites, but alpha 2 inhibits. So if you have epinephrine in your system, well, isn't it kind of like counterbalancing itself? Well, again, this is where the concept of different receptors, different effects. Not every cell is going to have every single type of receptor on its surface. So what your cells do to kind of select for what activity they want is that they only will have certain receptors on their surface. So epinephrine will only have, like if you want a cell that only causes excitation response to sympathetic activity, maybe you want only alpha 1 receptors on there. So this is how your body is able to determine different, so same chemicals, same epinephrine, norepinephrine, but by changing which receptors are on a cell, you can change its response to sympathetic or parasympathetic activity. Now, parasympathetic neurotransmission, let's go over this real quick. So preganglionic and postganglionic, what we have is that target organ. So we have, luckily, this is pretty easy. Between preganglionic and postganglionic, in both sympathetic and parasympathetic, you have nicotinic receptors, so that's pretty easy. But when you have the postganglionic neuron in the parasympathetic nervous system, you instead of releasing norepinephrine and epinephrine, you have acetylcholine being released, and this is going to bind to muscarinic receptors. So there are no adrenergic receptors in the parasympathetic nervous system. You have muscarinic. And luckily the mnemonic is a little easier here. So this is why it's pan, because why you have parasympathetic up there, and then that the pan part refers to this acetylcholine binding to nicotinic receptors, and this part right here, the am part, refers to acetylcholine binding to muscarinic receptors. The acetylcholine being released by postganglionic neuron, and muscarinic receptors being on the surface of tissues or organs that respond to parasympathetic activity. Now, nicotinic receptors, there are many types. Don't worry about this for this class. Again, if you're going to pharmacology or med school, yeah, you kind of have to know those. But yeah, don't worry about them for this class because it is a rabbit hole. Muscarinic receptors, there are subtypes, but compared to the alpha and beta ones, I don't want you to really focus on that. Maybe that's more reserved for advanced A&P and definitely more of a med school, pharm school kind of topic. So, but both of these receptors are found in the parasympathetic nervous system, and both of them are binding to acetylcholine. So there's something called nicotine, there's something called muscarine, but in your parasympathetic nervous system, the natural activators are acetylcholine. So again, acetylcholine is super powerful neurotransmitter. You have it with your neuromuscular junctions, and you have it in your autonomic nervous system. So this is why acetylcholine is super important. Now, we're going over time, so I'm just going to try to finish up with the sympathetic pharmacology. So I think this is also covered in OSU. So if you can stay on, that's great. If you can't, by all means, go to your next class. So you also have a class of drugs. It's not just one type of drug, but sometimes you have like drugs that have similar activities or they work in similar ways. So that's what we call a drug class. So one of these classes of drugs are things we call sympathomimetics, right? And mimetic sounds like mimic, right? Or mime, like those creepy French clowns that do that, like, and pull that rope thing. So like they sound like that mime, like they're mimicking, they're acting like something. So this is what with the sympathomimetics is that they act like your sympathetic nervous system. So these are adrenergic receptor agonists, but they're not the same as your natural sympathetic nervous system. But they activate the same receptors. So that's why they're mimetics. So they're going to activate adrenergic receptors, alpha or beta receptors, and they cause sympathetic effects. So that's why it's sympathomimetics. So it includes things like amphetamines, pseudoephedrines, MDMA. So a lot of these recreational drugs, like I remember back in San Francisco when I was in grad school, you could tell who was like on something because like it was like, wow, it's like 40 degrees out, but they're sweating up a storm, they're shirtless, and their pupils are freaking huge. And why? Like, oh, yep, they definitely have some sort of sympathomimetic in their system. But yeah, that's what sympathomimetics do. Notice that a lot of these are, the colloquial term is also uppers. Notice that a lot of them are kind of stimulating these, and this is why sometimes the people experience cardiac arrest. They're taking so much of these drugs that their heart overloads and it just stops altogether. So that's why sometimes I haven't heard too many stories. Like all our news is occupied with other things right now. But once in a while, like when I was in grad school, you hear about somebody taking one of these things for the first time and dying. Well, that's why. And then sympatholytic drugs. So what these are antagonists. So lytic sounds like lysis, right? So lysis, it means breaking apart. So these are kind of like breaking apart the sympathetic response. So these are antagonists. They bind to the same receptors, but instead of actually activating them, they're binding to alpha and beta receptors, but they're blocking adrenergic receptors. And caffeine and nicotine fit in this category. Oh my god, so yeah, caffeine is funny, like it stimulates, but it actually activates so many receptors. So yeah, it's not different, it's related, but yeah, nicotine is going to fit that because again, indirectly. And this is why we often get things with like people who have nicotine withdrawals or they have too much nicotine overdose. Well, nicotinic receptors are also found in our autonomic nervous system, right? So this is why nicotine is a very powerful regulator of this autonomic activity. But back to sympatholytics. So these drugs, instead of actually activating the sympathetic nervous system, it's going to tone it down. So it's in there, not the same as parasympathetic, but it's going to basically just like pull sympathetic activity lower. And indirectly, so again, it's not quite the same, but produces parasympathetic-like effects. So in dually innervated organs or tissues where they oppose each other, yeah, a sympatholytic is going to act like a parasympathetic activity, but they're more indirectly. It's more just due to blocking sympathetic activity, not necessarily increasing parasympathetic activity. So these are often called blockers. So alpha and beta blockers, and this is why they're not directly parasympathetic. These aren't binding to muscarinic receptors. They're binding to the same receptors as the sympathetic activity and epinephrine and norepinephrine. But instead of activating these alpha and beta receptors, they're blocking it. And what can you do to relieve sinusitis? So this is like for decongestants, and this is like pseudoephedrine and epinephrine. I think we might have covered this earlier. But this is where we come back full circle. Like remember when we were talking about the sinuses in your skull? Well, what's going to happen with these agonists in at least the blood vessels inside your sinuses? It's going to shrink the blood vessels, thereby reducing blood flow. And this reduces mucus production in your sinuses and also prevents the accumulation of fluid as well, and blood and fluid in these tissues. So that's why when you do have a alpha-1 adrenergic receptor agonist such as pseudoephedrine and phenylephrine, this shrinks the blood vessels, thereby reducing the swelling and mucus production in your sinuses. That's why you can breathe better. Now with this, you may have also seen this with adrenaline. So adrenaline in the heart, like in so many movies, what they have is like someone has cardiac arrest, they say, okay, I need epi-stat, and they jab the needle in there, forget about any sterility, and this person immediately wakes up. So again, adrenaline is the same thing as epinephrine. So epinephrine, the natural sympathomimetic, or not sympatholytic, it's what we call endogenous. It's your natural ligand for the receptors of the sympathetic nervous system. So what's that going to do? Well, it's a beta-1 agonist. With the adrenaline, and epinephrine, it's going to increase your heart rate and cause stronger heart contractions. And that makes sense because if someone's heart is stopped, you want to get it beating again. So this is why epinephrine is commonly given. And bronchoconstriction. So remember, bronchoconstriction is narrowing of the airways, and many diseases, especially asthma. Now, but there's other ones too, like emphysema, chronic bronchitis, COPD, and even exercise-induced bronchoconstriction. Sometimes this happens as well. So one way of undoing that is by opening up the airways, right? So actually, they do give a combination therapy, but that's more med school level. But one of the drugs they give are beta-2 agonists. And salbutamol, well, actually they swapped it, but again, I won't get over too much details, but this is one example. Now, let's talk about that. So what it's going to do when your airways are narrowed, you want to open them up. So with beta-2 agonists, salbutamol or albuterol is going to open up the airways. So again, if someone's wheezing because their airways are constricting due to asthma, you want to open it up, give them a beta-2 agonist. This is going to open up your airways. So this is short-acting, but actually they're going more for long-acting beta agonists. I have to update this slide later on. And okay, so what we have here is an allergic response. Now, this is a little more advanced. We cover allergies for actually, do we even have time next semester? Well, this involves the immune system. Don't worry about all of the immune system stuff right here. But what we have here is increased blood flow due to allergies, and also the blood vessels, they start to open so much that they also become a little leaky. And when you have this leakiness, all the fluid from our blood vessels ends up going to the surrounding tissues. Now, there's something that we call anaphylaxis. And so anaphylaxis is a medical term referring to what happens with a severe allergic reaction. And this is when the immune response, so the thing is that with the allergies, this is our immune system reacting to something foreign or something that causes an allergy. And what happens is it kind of goes extra, so you want to deliver immune cells to the area and thereby help those immune cell system by delivering more blood to the area. But if it kind of overshoots it. Now you have too much blood going to that area. So the other thing is that anaphylaxis also causes bronchoconstriction. It's due to the swelling and also the constriction of this airway, swelling of these airways as well. And a lot of these blood vessels all throughout your body start to dilate. So this can cause major swelling, like this poor girl right here. Like, yeah, this is not plastic surgery. She has some severe, I forgot where this source was, but yeah, look how puffy her eyes are, her lips, like that's not collagen injections, that is like severe anaphylaxis. Luckily, I think she recovered enough to post this later and admire her bravery, but yeah. But what happens if you have too much of this blood and fluid leaking out from these blood vessels to the surrounding tissues? Well, without blood and fluid inside your blood vessels, your blood pressure drops. It's like having a lack of water in your pipes. You're going to have a lack of water pressure. So this is why anaphylaxis can be potentially deadly. And if you don't have enough blood flow, you can also lead to your heart stopping altogether or cardiac arrest. So what's a common way of treating anaphylaxis are these epinephrine auto-injectors, or EpiPens. And actually EpiPen I think is a trademark one. Now they thankfully have generic versions, because I think last time I checked it was like hundreds of dollars for the name brand. It was ridiculous. But if you look at EpiPen, what does it do? And what it does is constricts blood vessels. Hey, constricting blood vessels. Therefore it's an alpha-1 agonist, right? Because alpha-1 constricts blood vessels. Beta-1 agonist, hey, where's beta-1? That's good in your heart, right? So it's one of the major ones that control your heart rate by increasing the heart rate and also increasing the force of contractions, thereby increasing the flow and circulation of blood. So increased blood flow. And beta-2 agonists. Beta-2 agonists, when you think of beta-2, easy mnemonic for beta receptors, beta-1, one heart, two lungs, right? So one heart, two lungs. So beta-2 is important in the lungs. It's going to open up the airways, because why? With anaphylaxis and the severe allergic reaction, you have the wheezing. So you want to open up airways and you want to restore circulation. Or if you know like emergency medicines, like what's the ABCs? Airway, breathing, circulation. So yeah, this is what it helps with all of those in anaphylaxis. And what are the side effects? Well, you're going to have things like pounding heartbeat. Yeah, that's kind of what we expect, right? With beta-1 agonists, we're going to have increased heart rate, sweating, sympathetic activity, right? This is the natural sympathetic ligand, right? So we're going to have activating the sweat glands. Nausea or vomiting, that's a little more complex, but breathing problems, maybe you're over breathing or whatnot. Paleness, dizziness, weakness, shakiness. So again, what happens when you have sympathetic activity in the fight or flight response? Sometimes you get kind of dizzy, shaky, anxiety, nervousness. So this is your fight or flight system being induced by this auto-injector. So it's not your nervous system, you're getting it from the outside, but it's causing the same activity like your sympathetic nervous system. Again, all those shakiness you get with sympathetic activity. So again, it's not random side effects. These are things we expect, because why? We know what receptors epinephrine binds to. Therefore, where do we have the sympathetic activity? What are the effects of sympathetic activity? What could be potentially negative effects? That's why we have this laundry list of all this side effects with EpiPen. Okay, way over time here, but again, this is very important, because again, if you're going to nursing, medicine, pharmacology, you gotta know this stuff, and these are powerful drugs, and this is why I love teaching about the autonomic nervous system, because again, EpiPen can be life-saving, works super quickly, and this is why a lot of the emergency department drugs are used to kind of like regulate the autonomic nervous system. Very powerful stuff, very useful. All right, so see you on Friday. Thanks for hanging in, those of you who stayed around, and see you then.